Okay, back to what we're talking about anatomically here with the low back. See if I forgot anything. The neurological structure here of the low back is really important. You can see here, this is the spinal cord, and it basically stops right in this area right here, in between T11 and L1, and this is the end of the spinal cord. And so, for the most part, in the lumbar spine, you have the cauda equina, and the cauda equina is just a collection of nerve roots. So you should never see any kind of upper motor neuron problem within the cauda equina, with a low back patient. So if you're seeing long tract signs with a low back eval, you're kind of barking up the wrong tree, because all you can see with low back problems are lower motor neuron. This is in contrast to cervical spine. Of course, in cervical spine, you do have the cord in that area, and many of the problems in the cervical spine can affect the spinal cord, and therefore you will see in a upper quarter screen, many times you'll see upper motor neuron disease. Okay. Now, the cauda equina comes down here, and all these nerve roots come down, and they come down and they go right under the pedicle here to exit the intervertebral foramen, and they come down right below it, and there is a gutter here through which this nerve root travels, which we'll look at and is relevant in spinal stenosis. But many times, just protrusions like this particular one here, involving the L5 or L4 disc, will catch the L5 root rather than the L4 root, or a large disc may catch both of them. And then as you go centrally here, central disc protrusions can catch roots anywhere below the location of the disc. So if there's a disc up in here that's protruding centrally, it might catch sacral roots from all the way up in the upper lumbar area, although most of the time a large percentage of disc protrusions are at L4 and L5. So that's the neuroanatomy, the general neuroanatomy that you got to be aware of, and the nuances of how these onion skin nerve roots come off, and how a problem at L5 may be operated on at L4. Of course, with our MRIs now, they're fairly resolute in determining exactly what level the neurosurgeon has to go in and fix. Okay. And we're going to talk about two areas of pathology in the low back, like I said, bony and soft. The first bony problem that we want to look at is spondylolisthesis and spondylolysis. Spondylolysis being a fracture type defect in the pars interarticularis, and this is usually developmental. Many times when the individual is in 12 to 15 age group, they will develop spondylolysis. However, there are documented cases of spondylolysis developing from severe trauma that can occur to cause this. But for the most part, this is called a developmental fracture deformity, and it's probably not very relevant until you get into this kind of thing, which is your spondylolisthesis. Spondylolisthesis, however, occur in something like 50% of Eskimos, and yet their incidence of low back pain and disease isn't any different than that of the general population. What does that mean? It just means that we can be walking around with a lot of this going on and a lot of this going on without low back pain. But when it progresses, many patients, it does develop into a painful syndrome. The spondylolisthesis is diagnosed with a lateral x-ray and is graded on a percentage of subluxation of one vertebra on another vertebra. This particular one being about a 25% grade 1 or stage 1 spondylolisthesis, and then this one is almost off the end. It's a grade 3 spondylolisthesis, and usually when you get into this kind of a situation, you get into a surgical fix, and I have seen those several times. So that's spondylolysis and spondylolisthesis, and when you're dealing with this kind of problem, you're dealing not only with a bony problem here and here. This is the cementing substance that prevents this from occurring. So in order for the listhesis to occur, you have to have the disc has to degenerate in here and here in order for this bone to go forward on this bone, because the disc holds these two together. So you basically got two issues here. You got a bony issue with the pars interarticularis, and then you have a soft disc problem here dealing with the cement substance between the two vertebral bodies. So that's the first bony problem that we're going to talk about. Now, the next bony problem we'll talk about are bony entrapment syndromes. And this particular slide shows the development of spinal stenosis. And with spinal stenosis, you have a narrowing of this AP neural canal. In the lumbar spine, the neural canal is fairly large and round to accept the catechoanae, but as you go down from L1 to L4 or 5, that neural canal becomes more treacle or triangular in shape. And as the bony deposit starts developing here in the laminar area and in the discal area, you have a narrowing of this canal, and it becomes really, this particular specimen here shows almost an amputation of this nerve root, because as you saw with the neural structures, that nerve root has come right underneath this pedicle here and out through this gutter. And as this builds up bone, it certainly creates problems for that nerve root, and then overall problems for the whole catechoanae here. And you can see these are real bones, and here's a neural canal for L1, which you can see is quite nice and large and round. And then when we get down to L5, you can see where it's changed its shape significantly, and now we have this more triangular type of form with these gutters here for the nerve roots to come out through. And again, they call this triangular compression spinal stenosis. Now, above and beyond just stenosis in and of itself, which is this narrowing of the neural canal, we also have other degenerative changes that usually occur concomitant with the change of the shape of the canal. And that is shown pretty much on this slide. Oops. This is collapsing disc disease, where you'll see this on X-ray a lot in X-ray findings, where the disc has actually lost its complete height here. You have bone on bone, and then you have a neural canal that has changed in size from something like this to something like this, and so that nerve root coming out here gets can get completely compromised, or at least somewhat compromised, as it exits the intervertebral foramen to go out to the periphery. So, and you get, as you get the degeneration here in the disc, and the separation of the disc from the bone, you many times get these osteophytes developing on both sides here, and sometimes well into the intervertebral foramen, playing the devil with that nerve root that comes out. So, they call these different problems disc collapse, overriding facets, facet capsular arthritis, ligament unfolding, ligament folding, and those are all degenerative problems occurring in this area. Now, what's the significance of them? The clinical significance is these bony problems usually occur in older patients, except with spondylolisthesis. Sitting is almost always more comfortable for them. Any type of extension or increased lordosis worsen their symptoms. These people should be flexed generally in treatment programs. Why? Flexion moves the pedicles apart. Flexion opens the intervertebral foramen. It opens the neural canal between segments. It extends the ligamentum flava. And with spondylolysis and spondylolisthesis, flexion actually decreases the stress on the pars interarticularis bone. So we do flex these people, and it does help them. It's a degenerative issue, though, that is not going to change significantly on a structural basis, but you can help these people with flexion routines. Okay, so that's the bony aspect of the low back problems. Now let's talk about the soft aspects. The soft aspects of the low back problem. We're talking about the disc. And we want to look a little bit at the disc structure. You've got the thick anterior longitudinal ligament, and you rarely see herniations this direction. And it's very thick here. You have the anterior annulus, which is really thick. And here you got the posterior longitudinal ligament, which is fairly thin, and you have a somewhat thin posterior annulus, and you have a location of the nucleus in the back third or 2/3 of the disc space. And then here you've got your cartilaginous end plate, and that's important because the disc itself is avascular. And the things that you hear about the disc healing are probably not true, because the disc itself really doesn't have blood supply. It gets its nutrient from diffusion of fluid between the body of the vertebra and the nucleus through weight bearing and non-weight bearing. In other words, during the night, through osmosis, diffusion, the liquid nutrients in the bone come down into the nucleus of the disc, supply it with nutrition, and then at night or in the daytime, as you get compression, that fluid all comes out of the disc, goes up into the bone, so you get a transfer back and forth every night, and that's how the disc gets its nutrition. So, this is the, like I said, this is the relative anatomical structure of the disc. And if we take a disc out and look at it, you have your annulus fibrosus and your nucleus pulposus, and the annulus is made up of, I think, 14 or 16 annular rings. And these are rings of cartilage that are kind of summed together with concentric fibers of collagen going in different directions. And these rings are held together, or they're kind of stuck together to give the disc a fair amount of good support.